Right, it's a minute past 1 now, and we've got a good selection of people who have joined today's calls, so I think we'll make a start. Good afternoon, and welcome to today's BHF Data Science Centre monthly webinar, and many thanks to all of you for making the time to attend. My name is Reuven Preden. I'm one of the Centre's research project managers with a focus on managing the CVD COVID UK COVID Impact research programme within our structured data thematic area, and I'll be chairing today's webinar. Today, we're delighted to welcome Dr Tim Wilkinson, a clinical research fellow in neurology at the University of Toronto and an honorary clinical lecturer at the University of Edinburgh. And his talk is entitled Antipsychotic Prescribing and Mortality in People with Dementia Before and During the COVID-19 Pandemic. Before I hand over to Tim, may I please ask everyone to kindly keep their camera and microphone switched off, and to make you aware that this webinar is being recorded and it will be made available along with recordings from our previous webinars on the BHF Data Science Centre's playlist on the HDR UK YouTube channel. There'll be time at the end of today's talk for discussion, so please post your questions in the chat and we'll do our best to answer as many of them as possible. Finally, if you would like to present a future webinar, do let us know in the chat and Kate McAllister, our communications manager, will follow up with you. So without any further ado, I'm going to now hand over to Tim.
Great, thanks, Reuven. I'm going to share my screen. Can you see that okay?
Perfect.
Great, thanks. So, yeah, thank you for that. So, yeah, I'm Tim. I'm a neurologist. I'm usually in Edinburgh, but I've been in Canada for a year. So most of this work was done while I was in Edinburgh. My rather long-winded title is really just looking at the idea of whether COVID-19 has had an effect on the way in which we prescribe antipsychotic drugs for people with dementia, and also looking at generally the effect of the pandemic on mortality and cardiovascular and cerebrovascular disease. So I'm going to start just by saying that everything I'm saying now really is in this paper, which we've submitted to a journal, but is also available as a preprint on medRxiv. You can see a QR code for that there if you're interested. And I'll start with acknowledgements. I just want to acknowledge the enormous amount of work that my co-authors have done in getting this ready for the world, particularly Christian Schneer there, the first author who did most of the analysis along with Aoife. So I'm really grateful to the co-authors and also the other people in the consortium that weren't co-authors but gave us great feedback on the manuscript and help us get things sorted. So thank you, I appreciate that a lot. And of course, big thank you to the BHF Data Science Centre, who've invited me to speak today, but also lead the consortium that made this work possible. And those of you who've heard me speak before know I'm a huge fan of the SAIL Data Bank, the Welsh safe haven for health data, and I think SAIL are fantastic. I'm going to talk about them a bit later, but this work is all using data from SAIL. But my most important acknowledgement is this little guy. So my son was born in January 2021. He was born very prematurely and he spent 3 months in the neonatal unit. And when he was well enough, we were allowed to hold him. But we weren't allowed to use our phones because they were worried about contamination, just with phones being pretty dirty things that we carry around with us. So we were told you can hold him, but don't have your phone. So I would spend hours staring into space, thinking, I guess, which is not something I normally do. And gradually I started bringing in a pen and paper and just writing ideas down. And this is where the idea for this work came from, this study, and the entire protocol really I drafted just sitting writing with a pen and paper. So without him, this definitely wouldn't have happened because I wouldn't have had the idea to do it, because I'm pretty sure I wouldn't have had hours not sitting in front of a phone or a computer. So thank you to him. But also it made me realize writing this how long research takes, because this is him now. So he's over 2 now. This is us enjoying the winter in Canada, doing some cross-country skiing. And it shows that even with the best of intentions, how long it takes to get research out there. But one of the delays in this was not due to waiting for actually access to the data sets, and that's thanks to the CVD COVID UK consortium. So it's nice to do research where I'm not being slowed down by waiting for access to health data. So thank you. So I'm going to talk about a bit of background about dementia generally and COVID-19. I'm going to talk about antipsychotic drugs and when we might give them to people with dementia. And then I'll go on to talk about our study in which we looked at trends of antipsychotic prescribing. We've looked at stroke, myocardial infarction and all-cause mortality. And we've also had a look at the effect of COVID-19 on deaths in this patient group. And I'll finish by talking about what we've learned. So a bit about dementia. Why study dementia? Why are we interested in dementia in relation to the pandemic? Well, unfortunately, dementia is very common. So this isn't a niche group we're talking about now. This is a huge portion of the population that we worry were disproportionately affected by COVID. So almost 1 million people living in the UK with dementia. So that's 1 in 71 of the population, but of course it's much more common in older ages. So 1 in 11 people over the age of 65 have dementia. And these are the people, of course, who are more likely to have comorbidities, more likely to be frail and are more vulnerable. And that has been shown since the pandemic has come along. So if you have dementia, you're more likely to contract COVID. And if you do contract COVID, you're more likely to become unwell and more likely to die of the virus. And so there's the effect of the virus itself, and then there's the effect of the restrictions, the lockdown restrictions. So in 2020, the Alzheimer's Society surveyed caregivers of people with dementia, and almost half of those caregivers reported that their loved ones had increased agitation or restlessness, increased stress and depression as a result of the social isolation relating to the lockdown restrictions. So you've got this really cruel double-edged sword of a virus that you're more likely to catch it and more likely to die from it, but also the restrictions trying to prevent the spread of the virus cause distress. And that's a concern because that might change the way in which we prescribe antipsychotic drugs. So antipsychotic drugs are used in dementia to treat symptoms of aggression, agitation, distress, and psychosis. And you can see the most commonly prescribed drugs there: quetiapine, risperidone, olanzapine. So we do use them, but we have to be careful about it, and that's because of the risk. So the background to this is in the early 2000s, randomized controlled trials suggested there was an increased risk of stroke if you use these drugs in people with dementia. And that led to in 2004, the Medicines Health Regulatory Authority issuing a warning about the risk of stroke with these drugs. In 2005, a meta-analysis of trials came out showing that there was increased all-cause mortality with these drugs, and that led to the FDA in America issuing what's called a black box warning. In 2009, the UK's Department of Health estimated that about 2/3 of people who with dementia were receiving antipsychotic drugs, and they calculated that might be leading to an extra 1,800 deaths and 1,600 strokes per year just in the UK as a result of these drugs. And more recently, it's been suggested there's an increased risk of myocardial infarction related to these drugs. I think the evidence of that is a bit more debated, but still it's a concern. And so where we're left in 2023 is that the guidance is very strong. It says these drugs should only be used as a last resort when all other options have failed. And of those drugs, only risperidone and haloperidol is an older drug we don't use very much for this problem, only they are licensed for short-term use in dementia, so for up to 6 weeks in an ideal world. So we can use these drugs, but we have to be careful. And this letter was written by Professor Rob Howard in London and some eminent colleagues to the Lancet Neurology in 2020. So they were keeping an eye on publicly available data from NHS England. So as a sense check, NHS England every month look at people who are on GP registers with dementia and whether they are receiving prescriptions for antipsychotic drugs. And that's an important sense check to check there's nothing strange going on, check there's no trends that are worrying. And Professor Howard and his colleagues spotted that it looked like around the time of the lockdown restrictions in March 2020 and the months afterwards, there seemed to be an increase in the proportion of people who were receiving antipsychotic drugs. And that's obviously a concern. And the concern is that this might be in relation to trying to prevent people, to help people with either adhering to lockdown restrictions or to help them with the distress. But this got taken up by the news. So ITV ran a news article about this, referring to it as a chemical cosh. So the idea that we might be sedating patients to stop them wandering, to stop them contracting or spreading COVID. So I think it was an important thing to look at. These are publicly available group level data, so they're pretty limited in in the inferences you can get from that. So we thought, well, let's use the opportunity to look at individual level data, and that's where the CVD COVID UK consortium came in to do our study. So I'm going to talk about that now. So we wanted to look at to see whether antipsychotic prescribing for people with dementia had changed before and during the COVID pandemic. And to look at whether if we did see an increase in antipsychotic prescribing, did we also see an increase in cardiovascular disease and stroke? And also just to look at mortality generally, and just to use this opportunity to see whether the COVID pandemic has had an influence on people's mortality with dementia. And to do that, we use the SAIL data bank, which I mentioned earlier. So SAIL stands for Secure Anonymized Information Linkage. And SAIL is essentially the safe haven, the trusted research environment for routine health data for Wales. And SAIL, so you have this population-based nationwide resource of individual level anonymized linked routine data. And the reason I particularly like SAIL is that they've managed to get primary care data for about 80% of the Welsh population linked to the other important data sets like hospital admissions and mortality. And I think primary care data are particularly important for doing research on dementia. And that's because fortunately, most people with dementia aren't in hospital. They're living at home in the community, they're living in care homes, but they're being looked after by GPs. This is a small study we did a few years back looking at people in the Edinburgh area who were members of UK Biobank who had a dementia code in any data set. And we just simply looked to see where were we finding these people? Where were we finding these dementia cases? And you'll see here that the vast majority of people were finding in primary care data. So if we are only using hospital or mortality data, the worry is, one, we're missing a lot of people. And two, we're probably biasing our population to the more severe end of the spectrum. So I think it's important to use primary care data, and that's where SAIL are particularly good. They're so good that a few years ago now, Christian and I approached Ashley at Bari and others in SAIL to say, could we do something here? So SAIL is behind the scenes in SAIL are billions of rows of raw data. And it's a lot of work and time in manipulating these data to make them ready for research. So what we did was create something called the SAIL Dementia eCohort, or SAIL DEC, where we took the billions of rows of raw data and tried to transform them into a research-ready, usable resource that anyone could come and use to do any sort of study on dementia in SAIL. So we derived dementia cases and the date that they were diagnosed, but also other comorbidities, so cardiovascular disease, stroke, Parkinson's disease, and risk factors, smoking, alcohol, and things like that, and drug prescriptions, using this primary care data as a spine. So we have this cohort, SAIL DEC, that's part of the CVD COVID UK consortium. So it struck us as a good idea to look at this issue using SAIL data. So going into the nitty-gritty, the methods, this was a retrospective cohort that was population-based using this routine data. Our study period started in 2016 and ran till 2021. Just as a reminder, because at times it's hard to keep track, the first COVID case in the UK was in January 2020, probably, and in March, that was when we had the first national lockdown. We identified everybody who was alive in 2016 and registered with a GP in SAIL at that time, and who received a dementia diagnosis in the routine data either before or during this our period of study. We excluded people who were younger than 60, mainly because dementia is fortunately rare in young people, and the codes are less accurate in that age. So they're more likely to be a false positive if we find very young people with a dementia diagnosis. So we just started at age 60. We looked at antipsychotic drug prescriptions. So they're in the primary care data. We can see that whether GPs are prescribing antipsychotic drugs. And our outcomes we're interested in were all-cause mortality, so death of any cause, stroke, and myocardial infarction mortality. Now, we looked at stroke and MI mortality rather than just diagnoses, like hospital admission diagnoses, to avoid an issue where it's very hard in routine data to tell whether somebody's having repeated events or whether it's the same event coded multiple times. So what I mean is, let's say someone has a stroke, they're admitted to hospital, they get a stroke on their discharge summary, and that's coded. A few months later, they're admitted to hospital, say with a chest infection, and on their discharge summary, it'll say chest infection and stroke, because that's in their past medical history, and they get another stroke code. So it can be very difficult to tell, is that person having repeated strokes, or is this the same thing being mentioned multiple times? So to avoid that, we looked at mortality, because of course you can only die once. That was the reason for doing that. Obviously, the disadvantage is we're massively undercounting the numbers of strokes and MI there, and I'll come back to that later. In terms of our analysis, we did what's called a time series analysis. So time series analyses account for seasonal variations. We know that in winter, people are more likely to die, and there's more flu and other infections going around at that time. So what a time series analysis can do is account for those seasonal changes over a long period of time, which is the reason for having the 5-year follow-up in our study. We age standardized it. So that meant that it accounts for the fact that if the population age had changed over time, let's say COVID killed lots of the very oldest people, and so the population changed, we would adjust for that by age standardizing the data. So we looked at the time series analysis of antipsychotic prescribing and death. And then very simply, we grouped causes of death in the same way that the Office of National Statistics do, and just looked at what were people dying of during COVID. So after COVID arrived in the UK, what were people dying of? So these are the results. So we had 57,000 people in the study. These are people with dementia, and the average observation time for them was 32 months. The average age at the study start date was 82, and 14% were resident in a care home at the start of the study. Just in terms of subtypes, 44% had an Alzheimer's disease subtype code, and 31% had vascular dementia, and there were other subtypes of much smaller numbers, and a proportion of people who don't get a subtype code. Of those 57,000 people, 21% were prescribed an antipsychotic drug at any point during the study. So this is what a time series graph looks like, and I'm going to talk you through it. So you'll see the 4 bars there, the 4 different lines. So the top one is just the data. So that's just what you're seeing when you age standardize the data. You're seeing peaks and troughs in antipsychotic prescribing every month. So that's sort of what you're looking at in a way with the publicly available group level data. I'll take you now to the seasonal trends. So what this does is it looks for patterns in trends over the years and accounts for that. So it shows you what it shows you the trends month to month, and you'll see, as we'd expect to see, just into the new year around winter, you see a peak in deaths. So that's what the seasonal data it does, and then the trend line is the most important. So that's the one we're going to look at from now on. What that does is subtract the 2. So you get the data, you take into account the seasonality, and you're left with the smooth trend line. And so what you can see here is for antipsychotic prescribing in people with dementia, from 2017 through to mid-2019, there is a gradual reduction in the rates of antipsychotic prescribing. And in the second half of 2019, that starts to upturn and increase, and that continues to increase throughout 2020, heading towards 2021. But you'll look at the rates on the left side on the y-axis, the changes aren't huge, and I'll come back to that, but in fact, I've got it here. So in March 2020, 12.9% of the population were prescribed an antipsychotic, and that was compared to 12.5% in March 2019. So there was an increase, and we shouldn't ignore that, but it was small. The absolute increase in prescribing is small. But it does look like that there started to be an increase in prescribing before 2020 that continued throughout 2020 on a background of reduced prescribing in the previous 2 years. We broke things down by age. This isn't time series, this is just the age standardized data, and each bar here is a different 5-year age group. I just want to draw your attention to the top one. So the age is 60 to 64. This is the youngest age group. Now, for some reason, the rates of prescribing increased pretty constantly throughout the entire 5-year period. And this is a big increase. So at the lowest point, our rate's about 1,000 prescriptions per 10,000 months, and that goes to 2,000 by the end. So that's doubled in the youngest age group, and you don't see that in the other ages. And that was a surprise to me, and I'm still struggling to understand why. So if anyone has any ideas, I'd be very grateful to hear them, because this is not what I'd expect, that for some reason we're prescribing these drugs much more. We're changing the way we prescribe these drugs over time, and we're increasing the rates of prescribing in the youngest people. So what about mortality? Well, 62% of people died during follow-up, and the median age of death was 87. Again, looking at the time series analysis and drawing your attention to the trend box that's highlighted. What you see with mortality is things are pretty flat over the first few years. You see a reduction in 2018 going into 2019, and then you see a really big upturn in the latter half of 2019 that then carries on during 2020 to reach a new peak. And you'll see just the top line, the data line, that spike there, that big spike is roughly March or April 2020. So that's when we were really hit hardest by COVID. And then you'll see that second spike at the end of 2020 heading into 2021, which is when we had that big second wave and we had to lock down again. So there does seem to have been a big increase in mortality around the onset of COVID, which is what we'd expect. And now this graph shows stroke and MI mortality. So if you look at the left graph, the stroke one, this follows a similar pattern to all-cause mortality. So things are pretty steady, then they reduce from 2018 into 2019, and you see this big upturn, not quite to the same height as before, but you see this big peak. And again, looking at the top line, the data line, you see spikes there around the time COVID transmission was highest in the UK. You don't see that pattern with the graph on the right with MI mortality. So with myocardial infarction, things are pretty flat, and then they reduce in 2018 over 2019, and they stay low. You don't see that big increase. So why might that be? Well, this graph looks at where the cause of the death and whether they had the stroke or MI in any position on the death certificate. Did it just appear anywhere, or did it appear as the underlying cause, so the primary thing that caused their death? So if you take a look at the stroke box at the bottom, the pink line is just stroke appearing anywhere on the death certificate, and the green line is stroke appearing as the underlying cause, the primary thing that caused the death. Where the dotted line is March 2020, when we were really hit hard by COVID. And what you see is a huge spike in stroke anywhere on the death certificate, but not such a big spike, stroke appearing as the underlying cause of death. And the gap between those things is bigger than it has been in previous months. You don't see that with myocardial infarction. So one possibility here is, what this makes me wonder is, people are having strokes, they're having more strokes, but it's not the thing that is killing them directly, or it's not the thing the doctor's writing on the death certificate. And I wonder if the thing they're writing on the death certificate is COVID, and they're having a stroke in the context of COVID. And I'll come back to that. While we're talking about COVID, just looking at the period from when, my lights have gone off, when from January 2020 to August 2021, 37% of people died. Of those, 19% had COVID listed anywhere on the death certificate, and 17%, so most of those, had it as the underlying cause of death. I think it's important to remember that certainly early on in the pandemic, we definitely weren't testing everybody. People were only being tested in a hospital, and even then it was patchy. So I suspect we're massively undercounting deaths, certainly early on in the pandemic. The median age of death from COVID in this population was 87 years, which is the same as from any cause. So it's not true to say that, well, COVID was just killing the very oldest and frailest in this population. That's not the case. We looked at the causes of death. So what were people with dementia dying of from January 2020 onwards? Now, unsurprisingly, most people, 42%, are getting dementia on their death certificate as the underlying cause. But if we ignore that, you'll see that COVID is the next biggest cause of death. And surprisingly, pneumonia and influenza are down there at 2%. Normally, we would think of people with dementia having pneumonia as a common cause of death. And I suspect COVID was replacing pneumonia and flu as the predominant respiratory cause of death in this population. So what have we learned, or what do I think we've learned? Well, antipsychotic prescribing rates did increase in 2020, but they started increasing earlier than that in 2019. The absolute change was small, and it was on a background of lower rates of prescribing over the previous 2 years. So we shouldn't ignore that increase, but it doesn't look as bad as was first as it first appeared using the publicly available data. But what is more worrying is antipsychotic prescribing in the youngest age group has increased over the entire period, over the entire 5 years, and I don't have a convincing explanation for that. We saw a large increase in mortality from any cause from late 2019 onwards, with particular peaks in 2020 and 2021 coinciding with the peaks of transmission of COVID in the UK. COVID has become the leading non-dementia cause of death in people with dementia, and that's, I suspect, an underestimate, certainly early on, because of the testing issue. And stroke mortality seems to follow the pattern of all-cause mortality, but we did see this shift towards stroke appearing as a contributing rather than underlying cause of death. And just to dive into that a little bit more, well, a recent study, meta-analysis, suggested that if you give antipsychotic drugs with dementia, there is a 16% increased risk of stroke. So one theory could be, well, we're prescribing these drugs a little bit more. Is that causing the strokes? But just remember that the absolute increase in antipsychotic prescribing was pretty small, and we saw a pretty big increase in stroke. So I suspect that isn't the only answer, if the answer at all. Our study design couldn't look at causality. You would need a different type of study for that. And there's different reasons why you might see a link between antipsychotic prescribing and death. So, for example, people get delirium because they have a severe illness. Antipsychotics might be prescribed to help ease distress during the delirium, and then the illness that caused the delirium kills the patient. It's not that the antipsychotic drug caused the death, so that's confounding by indication. Or people could be dying, and to ease distress, palliatively, antipsychotic drugs can be prescribed. That's reverse causation. Again, it's not the drug causing the death. I suspect that the majority of this increased stroke mortality is relating to COVID-19. So since we started this study, research has come out showing that if you catch COVID, you're at an increased risk of stroke afterwards or during that period. And I suspect that a lot of this increase is people getting COVID, having a stroke as a result of the COVID, and them having both things recorded on the death certificate. But I can't prove that with this study. Limitations, as I said, we couldn't look at causality. We can just draw inferences and come up with theories. As I said earlier, we only looked at fatal stroke and fatal MI to avoid this issue of double counting, but that will hugely underestimate the true rates of these conditions. And it's possible that we would see different patterns if we looked at any stroke and any MI, if we add in the non-fatal ones. With any time you work with mortality data, you need to bear in mind that they're imperfect, that there's lots of reasons why doctors might write a certain condition on a death certificate, and generally death data has lower predictive value. It's less accurate than other data sets like primary care data, but it's the best we have. And as I said earlier, the lack of access to testing for COVID early on in the pandemic means we're probably underestimating the effects of COVID mortality, and there are other studies that have looked at that since. So just last thing to say, I think it's important to remember that antipsychotic use is sometimes unavoidable. We sometimes do have to give these drugs to patients. Don't like doing it, but it's sometimes in their best interest. But we should remember to deprescribe where possible. So they should act as a sense check, and we, wherever possible, review the fact they're on these drugs and see whether we can stop them. I do think we need to look into why prescribing of these drugs has increased in the youngest age groups. And lastly, I want to say that I think the BHF Data Science Centre and HDR UK are really leading the world in showing us how research can and should be done. So in terms of facilitating access to data sets, in terms of open science techniques and collaboration, it's been a really great experience being part of the consortium. And I think long may that continue. So thank you to them, and thank you to all you for listening. Happy to take any questions.
Many thanks for that, Tim. Unfortunately, I have just dropped out of this call and I've lost access to all of the questions in the chat. due to my dodgy internet. So Kathy or someone else on the call, I wonder if you could step in.
Yes. Oh, well, yeah, no, someone else has stepped in. Go for it.
No, Reuven, I was just going to say I can post some. I'll post some back to you. Hang on one sec.
So one question that came up, there's a few questions in the chat actually. So one question that Laura's raised a couple of questions. One was, what's the mechanism that antipsychotics are thought to cause strokes in the elderly? I thought you should probably be in a good position to address that one, Tim. And also suggesting that perhaps the reason you see that increase in antipsychotic prescribing in the younger age group, the 60 to 64s, is because those individuals aren't classed as elderly. So I'm surmising, this is Laura's suggestion, that maybe that means they're considered not to be at such high risk of receiving the antipsychotics. So where you might have seen such an increase throughout the pandemic in all age groups, you've seen it just confined to that younger age group. I don't know whether that strikes you as a plausible explanation, but it'd be good to have your thoughts on both of those.
Yeah, so I'll start with the last one. So yeah, I mean, that's a really good theory. I like that. What we'd need to do is usually psychiatrists prescribing these drugs, particularly old age psychiatrists. And so it'd be really interesting to hear some views from psychiatrists. I don't know if there's any on the call. I think that's a good theory. So it might be that we're very aware that these drugs can cause harm. And so we think, well, if they're younger, maybe they can get away with it. I mean, I'm not sure the evidence shows that actually. So even if you give these antipsychotic drugs to people without dementia in younger ages, there is an increased mortality there as well. Now, presumably that mortality is highest in the oldest people, but I don't know that for sure. But for example, if you take these drugs because of schizophrenia and you're younger, there is a much more increased risk of cardiovascular and cerebrovascular disease in those people, although that association is very complicated for several reasons. But yeah, it's a good theory. It might be that people are becoming more aware of the effects, more cautious about prescribing it in the oldest group. Why that means they're more willing to give them to younger people, I'm not sure. So if we saw that just over time there was a difference in the proportion of people prescribed in younger people more likely compared to older people, but what we're saying is that just in younger people it doubled over time. That's a bit of a worry, I guess, but I think that might be part of it. It's a good theory. As to the mechanism, I don't know, and I don't think anybody knows for sure. So in the long term, these drugs can be associated with weight gain, which might be part of the reason for the increased risk of cardiovascular and cerebrovascular disease in younger people. That's less plausible for older people, I think, and who are often very frail prescribed these drugs. And I think there are various theories biologically about why these drugs cause death and strokes and maybe MI, but I don't think it's been proven, and I'm not convinced by them. So I don't know is the answer.
Thanks. Well, some good suggestions and reflections there, nonetheless. And we're not trying to over-egg the role of epidemiology and giving causal explanations for everything, as indeed we shouldn't. So some other questions here. What about different prescription formulations? Is there anything you've been able to do on that in the data, either in this study or more broadly?
Do you mean tablets versus depot? Or do you mean just sort of dose?
Yeah, sorry, like in the chat, a question from Jocelyn. So she says, have you looked, for example, at splitting up a 40 mg pill into 2 times 20 mg pills where applicable? So how much of these changes, if there are any, might be explained by different types of different ways of taking the meds?
No, it's a good thought. So one reason you might see change is people giving just for example, you might see a reduction in prescriptions because people are giving drugs, giving more at one time, so they're not having to prescribe it as often. So it's a really good theory. We did look at, so you can't look at that as well in the prescription data, but you can look at that in the dispensing data because you get more information. So this is dispensing pharmacies, you get more information on the dose and the pack size there. We did look at that. We didn't include it in the primary analysis, but we looked at that more from looking at the duration. So bearing in mind they're licensed for up to 6 weeks, how often were people receiving the drugs for 6 weeks or less, and how often were they being prescribed them for longer? And what we found was kind of what I'd expect, is that lots of people are prescribed them for 6 weeks or less initially, but generally over time, people end up needing it for a lot longer than that. And so you do see, even when you account for the pack size and dose, people are on these drugs for quite a long time. But it's a good thing to think about in terms of just looking at the prescription data and why you might see changes.
Yeah. And then a question on mortality. So do you think that the increase in mortality is directly due to COVID-19, or do you think some or all of it might be due to the health service response and capacity? So indirect impacts of COVID-19?
No, it's a really good point. I guess probably the answer is both. We do know that there seemed to be a drop-off in lots of the conditions we would normally expect to turn up to the emergency department, stop turning up to the emergency department early on in the pandemic. The worry being that people are having, say, myocardial infarctions at home and not going to hospital because they're worried about catching COVID. And so there's behavior that might affect it. And then there's the health service itself. I guess I can say anecdotally, because we, I guess, suddenly created capacity in the NHS, certainly in my hospital. I wasn't aware of people coming to direct harm as a result of inadequate access to care once they were in hospital. There were decisions being made about intensive care and whether you would put someone on a ventilator early on. Probably that doesn't make a massive difference for the most frail population with dementia, who probably wouldn't be going to intensive care anyway, but it's not impossible. So I think that's a really good thought as well. I mean, still, we saw that almost 20% of the time doctors are writing COVID as the underlying cause of death on the certificate, but it's absolutely true that it might be that patient behaviors and healthcare services might have had some influence there. So I guess in some ways that's still caused by the pandemic. It's just not a direct cause from the virus, but yeah, it's a good point.
Yeah, absolutely. Some feedback and questions from Tim Chico. So Tim wants to congratulate you on your baby pictures, which I missed because I was late joining. So yeah, really sorry about that. Although I think I might have had a privileged early view. Okay, so also Tim asks, is it worth looking at the period between diagnosis and use of the antipsychotic and the outcomes? Perhaps as one way of disentangling causal pathways or shedding some light on that. And also, did you see any evidence of deprescribing of CVD preventive medications in people on antipsychotics specifically?
So both really good questions. We didn't look at deprescribing of CVD medications. I know that Risha Sofat, who's a co-author on our paper, and Caroline Dale and others have looked at that using the sort of CVD COVID UK consortium, looking generally, not in people with dementia, but generally changes in practice of prescribing of cardiovascular meds. So I don't know if either of them are on the call, but they might be better to speak to that. But we didn't look at it in this population, but it's a good thought. So I guess what you might be saying there is if people aren't going to their GP getting their statins, then perhaps that's having an effect. We didn't look at the period between diagnosis and use of antipsychotic drugs, but actually that's a really good idea. So I was trying to work out why we might see this increase in the youngest age group. And one idea I had, and it's perhaps not plausible, but is if, let's say, it's harder and harder to get access to an old age psychiatrist because they're massively overwhelmed anyway, because there's not many of them and there's enormous number of people with dementia. What that means is your waiting lists are long, and by the time and they get longer and longer over time, by the time you see somebody and get a subtype, by the time you see someone get a diagnosis of dementia, you're more severely affected, and so you're more likely to get an antipsychotic drug around the same time you get your diagnosis of dementia, being a younger person. Possibly that's one sort of theory I had, although I'm not quite sure. But it's definitely a good idea. It's worth looking at, because it might be that looking at whether people are getting prescribed these drugs soon after diagnosis or a long time after diagnosis might give us some clues in the data. There are probably better data sets to look at that in the UK. I'm thinking of CRIS data in London and elsewhere, where they have more granular data on the severity of dementia at the time they get a diagnosis, at the time they get a prescription. It's hard to look at that in routine data. So maybe I'll try and give a nudge to the CRIS researchers if they want to look at that.
Brilliant. Thanks very much. So I noticed we've got a few, we're coming to the end of our time, but I noticed we've got a few of our public and patient contributors who've very bravely joined us today. And I just wondered if you had any reflections on this work and its potential relevance and impact for patients and members of the public, with the emphasis on kind of prescribing, deprescribing, potential effects of the pandemic on the way in which pills are prescribed or not. And so there's no pressure, of course, but just wanted to create a bit of a platform for any of you who might want to ask Tim any questions.
Yeah, if I may, Kathy, it's Phil Blakelock.
Phil, please go for it. Yeah.
I was most impressed by this because I'm a bit of a data person myself, being a patient and a kind of physicist engineer. To be honest, this is the first real data that I've seen any concrete conclusions being reached from. I'm sure there are many more. So I'd say to Tim, it's to his credit that he's pursued this for 2.5, 3 years and come up with quite clinical, if you will forgive the pun, outcomes from the data that he's analysed. So well done. Need more of this.
Thank you. I appreciate it.
Thanks very much, Phil. And just to encourage anyone who hasn't had the opportunity to speak up or ask questions, do get in touch with us. You can do it directly via Tim, or you can send questions via the BHF Data Science Centre. If there's anything you want to raise that you didn't think of or have time to ask during the course of the presentation, I think all of our researchers really value these opportunities to get broader feedback. I imagine that Tim's already thinking about various things he wished he'd put in the discussion of his paper, and he'll probably have the opportunity to do so when it comes back with various referees' comments. So these sort of sessions are as useful for the researchers who are presenting and the feedback they get as they are for all of you listening. So thank you very much. Tim, any final thoughts from you before we wind up the seminar for this month?
No, but just thanks for the opportunity. And yeah, if anyone has anything they want to ask or say, feel free to, they can email me, contact me on Twitter, or I'm happy with that.
All the usual social media platforms. Excellent. Right. Thank you very much. Thanks everyone for attending today's seminar. We were slightly nervous we weren't going to get a good turnout, but we've had because of competing workshops and things going on elsewhere, but we've had a brilliant turnout as ever. So keep on coming next month, and we look forward to seeing you in the future. And thanks very much to Tim.
Great. Thank you, everybody.